All right.
All right, so aliquot number one here. So this is a 50 something, oh, full screen. Give me one moment. 50 something year old male who presented with cough for months long duration. While the cough remained dry through all of this, he did have one recent episode of small volume hemoptysis, no more than 1 tablespoon. He did not feel this coughing up of blood was from epistaxis. Other than some low grade chills, he has not had high fevers, sore throat, sputum production, or wheeze. He's a security guard, so generally active. For his progressive cough, he originally went to urgent care like about a week prior to presentation, where he was given a prescription for a Z-Pak. And since his cough basically became more and more frequent, about having a coughing fit once per minute, even, he also started to have some worsening dyspnea and exertion. Really, those two things, the dyspnea and exertion and worsening cough, he decided to come to the hospital. He didn't have any orthopnea. He felt that this exertional dyspnea was mostly related to uncontrolled cough. He can usually walk up a few flight of stairs before having to rest. So for his past medical history, he has a no non-ischemic cardiomyopathy with a EF of 30%. For this, he has an AICD. He had a left heart catheterization a couple years ago. It showed mild CAD only. He's had recurrent DVT 2 times in 2 separate years a couple years ago. One of these was felt to be unprovoked, so he takes Xarelto. Otherwise, he has CKD3, insulin-dependent diabetes, obesity, and actually on this presentation, just incidental radiologic compensated cirrhosis secondary to NASH. They basically found a cirrhotic appearing liver, but no signs of cirrhosis on presentation. So that's aliquot number one.
Oh, so many juicy things, Andrew, for us to discuss. Thank you so much for presenting. So, I'll just kind of talk a little bit about the HPI and then ask Jack to share his thought as well. So, the patient is coming in with about a month of cough, which kind of puts a nice bracket to kind of chronic a time frame for cough. When I think of cough, I usually think airway irritation. So the question becomes like, what is irritating the airway? Usually, with coughs, we think like maybe upper airway more than the lower airway, although there's things in this past history that makes us concerning that patient has multiple different risk factors as to why he might have a cough to begin with. Usually, when it comes to cough, I want the thing that I try to put my finger on, is there any alarm symptoms that we should be aware of or worry about? And although this patient has, and the patient has some hemoptysis, so that's something that, I will want to be able to explain as well. It sounds like it was like a small amount of hemoptysis, so I'm not activating my large volume hemoptysis schema. But in terms of just like thinking about hemoptysis, usually like the most common things is like parenchymal issues like bronchitis is really, really common, and we see it a lot often. That can cause some irritation, like followed by like kind of bronchiectasis, cavitary lesions of some sort. And the ones that is like more no misdiagnosis to think about is like kind of the vascular pathology, to think is there any connection between an artery, a capillary, or a vein that would lead to hemoptysis. Like, a vein, I usually think about heart failure, right? If there's like a backflow coming in, irritating that, there's a connection between like kind of alveoli, can you get hemoptysis that way? Is there anything with the capillary, which for like, diagnostic reasoning nerds, like, DAH, like AVMs becomes interesting to think about. And then like in the artery one is usually leads to massive hemoptysis. And those are like kind of like your no misdiagnosis. If there's like any fistula formation, they tend to be more on the massive side of it, and like post-surgical complications. So whatever we have to figure out, we need to explain the cough that lead to hemoptysis as well. So I'll let Jack layer on. What are your thoughts, friend?
Well, I think your approach to the cough and the hemoptysis was absolutely brilliant, and I think I appreciate so much both layering on the presence of what seems to be maybe not large volume hemoptysis yet, but also the presence of this shortness of breath and how that sort of localizes us to at least the lower respiratory tract causes of cough. And I think where my brain is sort of circling now is to say, how can we use this background information to help to start to prioritize some of the elements of this initial presentation. And if we look at the things in his past medical history, I think there's two things that are really jumping out at me that can help to frame the probabilities of some of those causes of hemoptysis that you mentioned. And those two things are the known history of CHF, as well as these prior episodes of DVT episodes, and then finally, the fact that he's on Xarelto. And the fact of the matter is that those three things can modify not only the causes, but also this individual's likelihood of developing hemoptysis. I think in terms of the heart failure, right? If somebody is in an acute decompensated heart failure exacerbation, exactly as Charmaine mentioned, the elevated pulmonary venous pressures will oftentimes lead to pulmonary edema. And sometimes some drops of blood can come with that fluid. And if you think about putting a couple drops of red food coloring into a glass of water, it's going to turn that food color, or it's going to turn that water red. And if we get some blood into the fluid that is the sputum and pulmonary edema, it can also lead to the development of some hemoptysis as well. But we have to temper the heart failure hypothesis based on the absence of a clinical signature of heart failure yet, right? We see that there's no findings that might floridly suggest heart failure, right, in the absence of orthopnea, but there is maybe a little bit of mild exertional dyspnea. So that's one way to think about it. The other thing is that this patient's history of Xarelto, right, is going to make anything that can irritate the airways or the parenchyma more likely to cause some blood in the sputum. And then finally, somebody who has had a DVT event in the past is at risk of potentially developing a DVT event again. And so that brings the possibility of a PE into play. Although again, that is tempered by the fact that having a PE through anticoagulation, while not impossible, is oftentimes improbable. And so I think if I sort of start to be like, well, gosh, where can we go from here? The only other piece of information that's maybe helping to frame this is the fact that there's some chills on exam. And if we abstract chills into systemic inflammation, right, we're sort of left with the same diagnoses that we were thinking about before, right? Bronchitis, pulmonary infections, as well as the more rare things to think about, like potentially underlying malignancy or a lung cancer. And so I think at this point, what this history does is it brings much more into play than it takes things out of play, but at least we can start to have some suspicion that the center of gravity, exactly as you alluded to, Charmaine, is in the chest rather than in the upper airway. But whether that's the heart or the lungs, we maybe have some things moving the needle towards the lungs, but certainly given the background history, the heart isn't necessarily off the hook here. And I think that sort of differentiation feature is really going to be what I'm trying to attune to as we look at the physical exam. Do we have evidence that says that there's elevated venous filling pressures from a heart problem, or are we looking at the lungs? And as you mentioned, that includes the parenchyma and the vasculature in the lungs.
All right, aliquot number 2. So I'm going to give you the vitals, the labs, and initial imaging. And this all came from the outside hospital, which thankfully we had the records for. So he did not require any oxygen when he came in. His vitals were pretty normal. His breath sounds were distant, maybe with some faint crackles. JVP is not appreciable. He had chronic pitting edema in the right lower extremity when you ask him if that's always been there. His initial labs showed a creatinine of 2 from a baseline of 1.5, a BUN of 40, normal sodium, potassium, chloride, and bicarb. His high sensitivity troponin was 34 and flat. His BNP was 6,400 from a baseline of 2,500. His CBC showed a white count of 8.1, hemoglobin of 16.7, a platelet count of 163. Blood cultures were sent and are negative. The procal was less than 0.05. The CRP initially was 15.8. That's a high sensitivity CRP. I forget the units on that. And then a non-con chest CT was actually the initial imaging modality of choice over there. And it showed a large right lower lobe and right middle lobe consolidation, which I'm just gonna pull up here really quickly so we can all take a look at it. Sorry to kick off the scribe. I'll give you control again in 1 second. Actually, hold on. I'll pause here for a second because I actually think the file is named with the diagnosis. So actually give me a second. I'll be back. I'll let you guys start discussing. We can take a look at it in a second.
I love how diligent you are, Andrew, and the fine attention to details I really appreciate.
Well, I would say this is uh, 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 starting to unfold in a way that I think is as anticipated, becoming a very rich case given Andrew's presentation skills and also just the ways in which you're laying this out. So I appreciate that immensely, my friend. Thank you. Maybe I'll just talk briefly about some of the physical exam findings and maybe a couple of the things on the lab, but we'll leave sort of some of the more advanced labs in the imaging to Charmaine here. I think while I wish that the physical exam really helped to advance our thinking, I'm having a hard time necessarily making any definitive conclusions based off of it, right? We have, I think, findings that, again, tell us that there is potentially something within the lungs, right, based off of the faint crackles on exam. But what those are coming from, right, is not necessarily completely clear, right? Because while we have crackles on exam, seems like we're missing some of the other key features that we would need to think of for acute decompensated heart failure, namely the absence of an elevated JVP. But again, we're also looking at a quite elevated BNP level compared to the patient's baseline. So potentially there is some increased left atrial filling pressures causing atrial stretch, releasing BNP, and that could be leading to these pulmonary findings on exam. So that's one hypothesis to go down. But then the other hypothesis to go down is to say that actually this creatinine of 2 up from a baseline of 1.5 is the thing that's mediated potential volume retention and the elevated BNP. And we're potentially dealing with a pulmonary renal syndrome as opposed to a cardiopulmonary syndrome based off of the patient's past medical history. And so I think those are sort of the two hypotheses that I'm pursuing based off of the exam, right? Are we dealing with the heart backing up into the lungs and it's maybe just an atypical presentation of heart failure, or is the center of gravity going to be related to this AKI and the lung findings that we have here? And beyond that, I will kick it over to you, Charmise, to take us through what other thoughts you have.
Oh yeah, I love your thoughts. I always try also think what lab surprised me. And when I heard this patient past history, hemoptysis, and seeing the hemoglobin of 16.7, I'm not really used to seeing normal to higher level of normal in most patient populations that I take care of. So I think that's interesting. So I think this kind of bear in mind that is this polycythemia of some sort. But again, hemoptysis was not bad. It was very small, so that wouldn't cause a big blood loss. But someone who has CKD stage 3, background of heart failure, I would have expected anemia here, and we don't see that. So it's just something to keep in mind as we go through the case. And Andrew, did you want to pull up the imaging?
Yeah, that would be a great time. I wanted this all bundled in that second aliquot. I think I've renamed everything. So let me, yes, okay. I don't know if you'll actually see the name, but I have a named no name here. So this is the original chest CT on admission. And I will zoom out. And is it okay if I give you a little bit more information just to kind of round things out a little bit? Okay. Perfect. So let me get out of here. So he was started on ceftriaxone and doxycycline, but he remained with symptoms 2 days later. So they performed a chest X-ray. 1 day after that, his CRP was greater than 300. So his CRP had increased, and this was his chest X-ray. I never see the reverse order, chest CT into chest X-ray. But this is the chest X-ray, and it has the nice arrow sign on it, kind of pointing to the same area on the chest CT that he had. And a little bit more. So they also performed an echo. It showed an EF drop to 20%. So that's actually why he was transferred to our institution, just for further evaluation of his EF drop. His vital signs remained stable when he arrived. And by the time I met him on the floor, he, for some reason, was transferred to the cardiac ICU because of the EF drop. But after he made it to the floor, he had by that time finished a 6-day course of community-acquired pneumonia coverage, with his cough being really only mildly improved. He felt it was improved, but only mildly improved. And he confirms that other than cough and dyspnea on exertion, with his dyspnea really only being related to cough, actually, he does not feel that he has an infection like pneumonia. And he also says he has new back pain, which localizes deep to the scapula on his right side. And it's quite painful, at least an 8 out of 10. So, really, just to summarize, he has this cough, but then this back pain as well. And I'll just stop there.
Um, Thanks so much, Andrew. So kind of going back to the imaging, both being right-sided, the one thing that I always like think about is like whether the patient is like an aspiration risk, because that's like somewhere these things tends to go. And thinking about like what this long mass could be, I think like, infectious etiologies come to mind. And then other than that, like, malignancy is right up there. And I don't know if this patient have any history of like smoking prior to this or not. And then I kind of think about like more like kind of autoimmune-ish things, like, like if that mass starts to cavitate, think about your cavitary lung lesions, and also like, GPA of some sort. With like the hemoptysis and everything else would be something to think about. Like those are like kind of the things that I'm considering right now. And like clearly, like the patient has some evidence of inflammation, like with the CRP that is elevated. Although, in someone who's like chronically ill, has history of cirrhosis, CKD, like it's hard to put too much stock in the inflammatory marker. I think the context that you evaluate these markers is also really important. The fact that, the patient didn't improve with the community-acquired pneumonia coverage, kind of like thinking about your antibiotic failure as well, is that like, hey, is there a bug that we're missing, or is it just not infectious at all? Jack, what are your thoughts?
I was just thinking through in my head about sort of activating the antibiotic failure scheme, and I think saying, do we potentially are we dealing with a non-cap organism, or are we dealing with no organism at all? Is the exact framework I'm taking to this. If we think about the non-cap organisms and say, okay, we think that this is likely that this gentleman with an indolent inflammatory pulmonary syndrome has a progressive indolent infection. The sort of organisms that I start to think about there are usually going to be fungal in nature, and I think the sort of which fungi we consider is going to depend on the immune status of the host, right? So we can think about in all comers, the endemic mycoses, right? Things like Coxsackie, at least for us over here on the West Coast, but not necessarily where Andrew practices up in the Northeast. And then also think about things like histo, which is endemic to the world. And then beyond the endemic fungal infections, for individuals who have underlying immunocompromise, and particularly profound immunocompromise, we can start to think about the molds as well. And the molds become relevant for two reasons, is that one, they can have very nauseatingly indolent courses and then rapidly progress. But the other reason is that they can potentially be angioinvasive. And one of the things that jumped out to me about the imaging findings there is that it looked like those sort of consolidations and opacities were particularly prominent around the vasculature of the lung fields itself. Now, again, that is something that is maybe tuning the reasoning here, but something that we would ultimately talk to the radiologist about. But the ways that angioinvasive infections tend to march through the lungs is they usually center around a certain vascular bed and then sort of march their way out into the periphery. The other organisms to consider alongside the fungal ones for these sort of indolent cap treatment refractory pneumonias are going to be the mycobacterial organisms. And then whenever we think about mycobacteria and fungi, the other two that I add into the infectious DDX are things like nocardia and actinomycosis. So I think those would be sort of the things to start to pursue from the infectious category, like you mentioned, Charmaine, and we can use some of those fungal markers, things like beta-D-glucan and galactomannan, to work up some of the molds and endemic fungal infections, and then start to ask ourselves, what is going to be our threshold for more invasive diagnostic testing in terms of things like a bronchoscopy? Because the other thing that the bronchoscopy could be really helpful with is characterizing the possibility of a non-infectious etiology, which would center on something that could be causing alveolar hemorrhage syndromes or underlying cancer, as Charmaine mentioned, right? If we see serial increases in RBCs on the bronchoscopy, then we've made a diagnosis of DAH and we can activate that DDX. Or if we see certain types of malignant cells that are sampled from the bronchoscopy, we may be dealing with an endobronchial tumor or a tumor that has made its way from the parenchyma into the airways themselves. So that's sort of some of the ways that I'm arranging right now. I think, as you were saying, from a acute morbidity standpoint, we would prioritize the infections, and then once those hypotheses have been falsified, we may turn more of our attention to the non-infectious causes.
I love that, Jack. And I think the other thing that was mentioned, that the patient has back pain, new onset back pain. So the question is like how that fits into everything, right? I feel like common things being common, honestly, in a lot of our patients, they're in the hospital for too long, they're in bed all the time, and they develop back pain is because they haven't been mobilized. Like the hospital beds are terrible. So most often, just like it's like key to like make sure the patients are working with PT, getting out of bed and everything. However, you also like want to make sure that if this back pain is related to the underlying pathology or not. So if it's new, just like doing a good, again, like re-examining the patient, is there any point tenderness, or where is the back pain localized to, doing a good neuro exam to see if there's any deficits there that makes you more worried about like a spinal process. Because if you, one way to frame it is like, is there a metastatic inflammatory process going on, right? If we are worried about underlying infection, could that be now a foci of initis of infection as well? If they're worried about cancer, is there any metastatic process that is causing bony compression fractures of some sort? So where the back pain, I would just kind of start a new repeat an exam, and then kind of think through, how is it relating to the lung findings, if it is. Anything to add about that, Jack?
No, I appreciate you so much, Brian. I'll be honest, my brain completely anchored to the back pain as being related to whatever process is happening in the lungs. I was just like, oh, there's something that is causing like some sort of inflammatory disease. It seems to be in the lungs, and like it makes sense that localizes to the scapula. So you actually pulled me out of a potential cognitive error with that reflection, and I absolutely love the approach that you shared. So thank you.
Well, both of those cognitive processes happened on two separate teams. So the first team that met him at my institution, they saw degenerative changes of the spine that was pretty severe. So they consulted orthopedics. Now, to give you some information a little bit more about the back pain, that's helpful. So he said, yeah, it's like on the right side of my back, it feels like someone's just stabbing there. And if he takes a deep breath in, it doesn't get worse, he says. He does it in front of me. But he says when I cough, it just gets like, it's at baseline at least a 5 or 6. But when I cough, it starts being like a 9 or 10, like it's quite severe. So what had happened, just to give you the real life story of how this unfolded for me. So I like pulled up, I looked at all this data on rounds, and I was frankly confused, and I'd activated the like antibiotic failure schema, but I didn't have an answer. I looked at the axial slices on the initial chest CT that I showed you, showing the consolidation. But then my attending on rounds, he pulls up the scan again, and we actually pull up the sagittal views of the original scan. And this is what I saw, and this completely changed the game for me. So this is the same exact chest CT from admission, just a different view. And at this point, we went to see him, and he told us a little bit more about his back pain associated with the cough. And this basically triggered a next test that led to the final diagnosis. Oh, also the aspergillus was negative. Someone did send that. Someone sent that before us. And there was an old ANA and an ANCA from like a year ago when he had another episode of hemoptysis that they were both negative. And that's it. Let me know what you think.
Yeah, I would say I am I'm going to come into this with a minimal degree of certainty and just sort of think out loud. So to sort of open up here to the group, I would say that I feel very uncomfortable and honestly a little bit nervous, because it seems like Andrew seeing this, it like activates something, and I'm like, I don't know what this is activating for me other than necessarily the need for more help, but I'll do my best to sort of interpret what we did see here. And then Charmaine, I'm very, very excited to get your help on it. Andrew, do you mind pulling back up the image again?
Yes, let me let me do this for you. Okay. And then to be fair, I'll also give you a coronal view, as I think that's also helpful as well. So this is this one. And then of course, right after we're like, oh, we should look at the coronals too. So here is the coronal view in case that's helpful too.
I wish it was. I wish it was. But I will say, looking at the pulmonary artery, Charmaine, I'm curious your thoughts. It looks like it's big. I don't know if that pulmonary artery looks big or dilated to you, but that is one thing that jumped up in my mind. But I'm curious, what else are you seeing there?
I don't know. If I'm very curious to learn from you, Andrew, as well. I think like the entire, like there's like the consolidation, like further down that kind of like looks like a consolidation that I expect, when I see a chest CD. The like the fluffiness of the mass that is kind of like buds the thoracic is like really interesting to me. It kind of looks like more like has like some maybe alveoli component to it. It's like a lot more fluffy than like the normal consolidation that I would see. And it's like budding the plural as well. So like the pluritic aspect of it makes sense. The other thing is that like if there's any breakdown of kind of the plural and if it's eroding away, then I think that would make me more concerned for malignancy. But to be honest with you, I'm like, this is the person that I would like just talk to radiology about, that I'm like, this is not something that I'm used to seeing on a CT. So yeah, I'm very curious to learn from you, Andrew. Yeah, tell us, teach us.
I did go to radiology at one point. We took a field trip with my medical student. So this was the subsequent study we got, and I'll explain in a second. I get this. So something I hid from the presentation that I think would have been probably helpful is he did have a PE on the right side earlier this year. But this was not at all on my radar until I saw that last scan. So basically what I thought when that came up, I didn't, on the axial, it's not obvious at all. But on the sagittal, the first thing that came to mind, I was like, is that a wedge? Like, is that a wedge shaped consolidation? It was not like exactly, I've never seen one before except on an exam, and they're usually like pretty like defined on exams and very obvious. But for some reason, my brain just thought like wedge, like is that a wedge? So I was like, we should probably scan him, because I don't know, infarction, and there was no signs or symptoms of pneumonia. He had PE history. He was taking his Xarelto religiously. He was, but I was like, we should probably scan him. So this was extension. I went down to radiology of his old clot. So he actually had progression of his old PE on the right side and the right lower lobe PA artery. It had basically been chronically occluded. And we looked at his old scan in June of the PE I'd hid from you. And apparently it already had features of a chronic PE back then. So he had chronic thromboembolic disease with an acute component back in June that was caught. And really this presentation was just progression and anticoagulation failure, causing interval pulmonary infarction. This had to have been like at least weeks before his presentation because of the chronicity of his illness. I walked the story through the radiologist and they were like, yeah, this is the largest pulmonary infarction I've seen. Actually, it's not exactly like kind of the classic shape, but with the whole history, they were like, this has got to be pulmonary infarction. So yeah, what are your thoughts? This was like, I did not know what to do with this in the morning. I just kind of had this epiphany, and that's literally how it went down. I don't know if my attending didn't pull up the sagittal section. I don't know if it would have been obvious, because certainly from the axial view, it wasn't obvious. But yeah, tell me.
Yeah, no, honestly, what a fantastic case, Andrew. Thank you so much for presenting this. Because yeah, from like even the sagittal, like my thought was like, this looks weird. Like I've never actually seen pulmonary infarction on a CT before. So I was like, this just doesn't look like the normal ground glass opacity, like consolidations, masses that I normally see. So I think that piqued my interest about like, this is weird. But I think like, yeah, you're absolutely right. The fact that it was in a territory that should have like clued us in about it, maybe a vascular procedure, vascular event. So this is so good. I learned a lot. Thanks, Andrew. This is really great. Jack, what are your thoughts?
Yeah, no, I absolutely love this case. I think, any case that further drives home the importance of epidemiology and script flexibility in terms of like all of the ways that or that relatively common diseases can potentially present. I think it's incredibly helpful. And I think two things that we're reflecting on is possible connections that I missed, which was one, the BNP potentially being related to like cardiac strain from basically probably underlying chronic pulmonary hypertension that was there, like of being like, oh, that's a learning point to get to take from the case. But then also, as you were saying, these sort of perivascular opacities, my brain went to either something like in the DAH realm or something in the infectious realm. But the framework for or having a PE as a part of that framework is also a new thing that I get to take from this case. So I'll be honest, I think it always feels not great to forget about such a common diagnosis like a pulmonary embolism, and that's also the best space for learning, is to take that feeling of like, oh, I didn't see it this time, I'm going to get to remember this the next time. So I'm incredibly grateful for that, for Andrew, for you bringing us again this sort of a new flavor of the not necessarily acute PE, but maybe chronic progressive PE presentation. And I'm curious to know, like, like, how was your team putting together the fact that this seemed to progress on Xarelto? Like, is there some thought of an underlying hypercoagulable state that may be working in the background, or just bad luck for him?
Yeah, I
Oh
love that,
yeah.
Jack. That's what my brain went to, is like, it's like, we're not done yet.
Oh, I love it. We had the same exact questions, of course, and it totally did change the way I think about PEs, because fundamentally PE acute. I didn't have this idea of like interval progression of PE with anticoagulation failure. That's just like completely, that wasn't in my realm of how to think about PE at all. So yeah, regarding the Xarelto, so we consulted hematology, and he was, I didn't get the exact BMI, but he's almost 40. So there's a question of also him having a gastric bypass procedure affecting the absorption of Xarelto. For him, he had a pretty extensive hypercoagulability workup in years past. And we sent a little bit of additional, but it doesn't seem like he has anything like that. So the leading hypothesis is maybe just poor absorption, like true anticoagulant failure versus a hypercoagulable state. And yeah, I'm trying to think of any other. Oh, the other thought, the feeding vessel. You all talked about like central vessel going into a space. So in like reading more about pulmonary infarction, I guess the feeding vessel sign is something you can see. I don't know if that's shown here necessarily. I don't know what exactly it looks like, but it sounds very similar to what you're describing in terms of like focal consolidation really kind of surrounding kind of something that feeds into it. So the airways here that kind of look like they're feeding into it, but I think along your thinking, that's something to look into, and I'll have to find a good example of that.
Awesome. Thank you so much, Andrew. I also wanted Robbie, if you're there, I saw that, I don't know if it was you or Charmaine who asked the question about the LDH, but I'd
If
love to
it's a
learn who that was.
thoughtful question, it's always Robbie.
I don't know. I think you're underselling yourself, but I was curious how that, for whoever asked that question, how that was playing into the reasoning here. Yeah, Boston. That's all right.
I have yet to look into degree of LDH elevation with infarction. I know that's like the classic thing that you see. Yeah.
Right on. Right on. All right. Well, Andrew, thanks again. I mean, this was a blast of a case again, masterfully presented, expertly taking us through what sounds like a quite twisty turny case, despite getting to the diagnosis relatively quickly. So I'm excited to hear from you, Mukund, in terms of the teaching points that you are extracting from this one.
Yeah, I think this was a tough one to summarize, because we went in so many different directions, but I will do my best. We started with a really interesting discussion about cough as a source of airway irritation, and moved into a discussion of hemoptysis. for which I have a differential diagnosis here. We talked about vascular causes, especially the cannot miss diagnosis of AVM or fistulas leading to large volume hemoptysis versus pulmonary parenchymal causes versus bronchial causes, of which bronchitis is overall the most common, versus pseudohemoptysis. And this is actually relevant because a friend of mine just had what ended up being an epistaxis drain that was worked up as hemoptysis, and it ended up being quite expensive for him. So I thought I'd throw that on the differential. We moved on to talking about a variety of different etiologies for volume overload as signs were seen in the lungs, and we discussed cardiopulmonary causes versus pulmonary renal causes. But we eventually moved into a discussion of treatment for this person's presumed community-acquired pneumonia. Of course, we later discovered that was not in fact the case, but when treatment isn't working, it is always helpful to activate the antibiotic failure schema. And I think I learned this from Jack on a different CP Solvers episode, a really helpful way of thinking about, are you treating the wrong bug? Are you treating the right bug with the wrong drug? Are you treating the right bug with the right drug, but it's not getting to the right place, or it's in the wrong dosage? Or is it just not infectious at all? So we talked about some of these things here today with a little emphasis on differentials for non-community acquired pneumonia organisms, so fungi, molds, mycobacteria, and other kind of weird filamentous bacteria. We also talked about it potentially not being an infectious disease at all. We took a slight deviation to focus on this patient's new back pain, which could be related to the pulmonary issues, but could also be a completely separate process. And so we talked about warning signs and danger factors and how to do a good physical exam and a good workup to make sure that you aren't forgetting about malignant metastasis, osteomyelitis, vertebral decompression, and other cannot miss causes of back pain. And ultimately, we settled on this patient's disease as being caused by a chronic pulmonary infarction. And I have included here a very nice picturesque image from Google of a wedge-shaped finding on imaging that is characteristic of a pulmonary infarction.
I'm still smiling because I'm like, yeah, this got me good. You have given me a lot to reflect on and think about, Andrew. So thank you, sir.
I'm so glad you had as much fun with this as I did. This was, yeah, I was just as confused as you until my epiphany.
I was in good
Yeah.
company then. I was in good company. That's all I asked for.
And this went by 4 different teams too. It makes me feel better. Yeah, thank
That
you
makes
too.
3 of us.
Yeah, now I think the list is like 7 now, or something like that. Thank you too for coming. This was awesome.
Awesome. Thank you all for joining us and for all your thoughtful chat discussions and chat as well. We'll see you next time. Bye.